I think you can start, Riddhima. Sir, he has given permission. Yeah, start.
Okay.
Hmm.
Okay. A very good evening to everyone and welcome to ISC online PG class. Today we have a very important and interesting topic, that is labor analgesia. Labor analgesia has come a long way from the days of ether and chloroform to an evidence-based practice. Let us update ourselves with the various strategies of providing labor analgesia today. As a customary, before we proceed further, let's have a blessing of Ma Saraswati.
सरस्वती नमस्तुभ्यं वरदे कामरूपिणी विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा।
I think Sir is, as he said, he is busy in some meeting. Now, I request Dr. Madhuri ma'am to kindly address the gathering and discuss the relevance of this topic before we proceed further.
Yeah, thank you, Riddhima. Welcome to the ISA National Online PG class. So these PG classes are very popular, and in these classes we include topics which are of interest to the postgraduate students, especially those which are covered in the theory paper and also those which we cover in the practicals, case discussions, and viva voce. And we also have many practitioners who attend these sessions. And the aim of these sessions uh, is to make the postgraduate students more confident in facing postgraduate exams, and of course how to be confident in clinical practice. So starting from basic sciences and case discussions and theory questions, many aspects of the curriculum are covered in these PG online classes. So welcome to one more session, and we have this topic of labor analgesia here today, and it is one topic which is evergreen, and we have started. The history of labor analgesia is very interesting, and today we have come a long way, and we have got so many modern strategies of providing labor analgesia. So we have a very interesting class to look forward to now, and I request Dr. Archita to please introduce our faculty for today's class.
Thank you, Kurdi ma'am, and Bajwa sir also for giving me this opportunity to coordinate this session. Thank you to Ridhima for helping me out with all the technicalities. Greetings to all on the occasion of Navratri, Durga Puja and Dasera. It is only befitting that this week's topic, labor analgesia, is meant to provide us with updates so that we can, to the best of our abilities, help our parturient mothers to be sail over the difficult period of delivery and labor by providing labor analgesia. We have very esteemed senior faculty members for our session today. Our first moderator is Dr. Shalu. She is, I'll just share her PPT. Ma'am is professor and HOD at the Department of Anesthesiology and Critical Care at the MOSC Medical College, Kolancheri, Kochi, Kerala. She is a fellow in palliative care medicine and also a BLS and ACLS instructor for AHA. She is faculty in national and international conferences and is a convener for Anesthesia Technology Training Committee, CMAI, New Delhi. Ma'am has various publications in national and international journals. She has also authored a textbook for BSc and Diploma Anesthesia Technician course. She is an examiner for MD and DNB anesthesia. Hence, she will be able to guide us for this session. Her areas of interest are obstetrics, pediatric, and palliative care. I welcome you, ma'am, for this session. Our next moderator is Dr. Shalini. She is Associate Professor of Anesthesiology and Critical Care at the MOSC Medical College, Kolancheri. In addition to MD Anesthesiology and DNB, she has also the European Diploma in Anesthesiology and Critical Care, the prestigious ADAC, in her kitty of degrees. She has been faculty in national and international conferences and also has various publications in journals. Her areas of interest are obstetric anesthesia, regional blocks, and pediatric anesthesia. I welcome you also, ma'am, and I now hand over the session to you so that you can take this topic forward and update us with labor analgesia. Thank you.
Good evening. Warm greetings from God's own country. It's a great honor for me and my team to be part of ISA National PG Teaching Program. I would like to thank ISA National, the Honorary Secretary, Dr. Bajwa, Dr. Mathuri Kurdi, and the facilitators who are with us for giving us an opportunity. Today's topic, labor analgesia, is one that is close to my heart. Our institution was one of the pioneers in the state of Kerala to initiate 24-hour labor analgesia services. We gave our first labor epidural in 1994 to our consultant gynecologist, and the legacy continues. Dr. Shalini Miriamai, Associate Professor in the department, will give us an update in labor analgesia. This will be followed by case discussion by our postgraduate students, Dr. Princey Sarah Thomas and Dr. Albin Joseph. Now, over to Dr. Shalini for the presentation.
Thank you, ma'am. At the outset, I would like to thank the Honorary Secretary, ISA National, and the ISA for this honor. We will be discussing the importance of labor analgesia. Can you see the screen?
It's not, please share your screen.
Don't worry. Okay, don't worry. Just give us a minute. Okay.
There must be one option coming, share screen. Fourth one, starting from the left side. You can minimize your PPT and then share it. Yeah. Yeah, it's visible. Can you do full screen? Yeah.
Can you see the full screen now?
Yes, yes. Perfect.
Yes. Thank you. We will be discussing labor analgesia, the different methods, concentrating more on central neuraxial blockade, how we do it in our institution, and the newer concepts. 60% of primees describe pain of labor as excruciating. So if all other pain is treated, why not labor pain? So does pain in labor serve any useful purpose? Pain causes suffering and loss of morale, especially in a parturian in prolonged labor. Pain leads to sympathetic stimulation, which can lead to hyperventilation and hypocarbia, which compromises uteroplacental circulation. The increase in catecholamines can decrease uterine contractions and also decrease the uteroplacental circulation, both causing fetal compromise. Sympathetic stimulation has deleterious effects on the heart of the mother, as well as causes maternal acidosis. So pain does not really serve any useful purpose. Ours was one of the first institutions to provide 24-hour labor analgesia services. And this is a picture of a consultant gynecologist, Dr. Miriam, who took the first ever epidural labor analgesia and MOSC in 1994. In earlier days, it was thought that relieving pain arrests labor, and hence analgesia should be given only in established labor. But now the ASA and ACOG recommends that maternal request is sufficient indication for pain relief during labor, barring any medical contraindication. Analgesia is provided on patient's request, regardless of parity, fetal station, stage of labor, whether early or at full cervical dilatation. Let's look at the pain pathways. In the first stage of labor, pain is due to the stretch of the lower uterine segment and cervical dilatation. It is visceral pain, which is poorly localized and diffuse. It is conducted by A delta and C fibers and accompanying sympathetic nerves that enter the spinal cord at T10 to L1 segments. The initial pain is dull, becoming severe in the late first stage. In the second stage and during delivery, the pain is due to descent of the fetal head and subsequent stretching of the pelvic floor, the vagina, and the perineum, and is mainly somatic in origin. It is transmitted through the pudendal nerves from S2 through to S4 segments. The most painful period in labor is the late first stage and the second stage. So, to achieve analgesia in second stage, we should block from T10 all the way through to S4 segments. Different modalities are available for labor analgesia, non-pharmacological as well as pharmacological. Pharmacological methods include systemic as well as regional analgesia. Non-pharmacological methods, as shown in this picture, is said to be very effective in early stages of labor, and it can be combined with other pharmacological modalities. Inhalational analgesia, self-administered intermittent inhalation of subanesthetic concentrations of Entonox and sevoflurane, can provide limited pain relief for a short time. Patient and the staff has to coordinate. The inhalation should start at the beginning of contraction, and peak effect should coincide with the peak of contraction. The safety factor is that when the patient becomes drowsy, the mask falls off, but nausea and vomiting may still occur. With Entonox, there is danger of hypoxic mixture being inhaled as the cylinder exhausts. Sevoflurane does provide superior analgesia, but is associated with more sedation and more depression in airway reflexes. Entonox seems to be on its way out due to environmental concerns as it damages the ozone layers. Systemic analgesia is the most commonly practiced modality due to its ease of administration. But pain relief is often inadequate as it is not repeated later in labor for fear of neonatal depression. In our labor suit, we give pethidine or tramadol with Finargan as an IM injection. Fentanyl and remifentanil in the form of PCA pumps is also said to be useful. Other modalities include midazolam, paracetamol, and even subanesthetic doses of ketamine in late second stage has been tried. Neuraxial analgesia guarantees pain relief all through labor and also allows the mother to take part in the birthing experience. The commonly used neuraxial techniques are continuous epidural and combined spinal epidurals. The newer techniques are single shot spinal, continuous spinal analgesia, and dural puncture epidural. The catheter techniques have the advantage that it can be converted to surgical anesthesia if the need arises. Epidural is the gold standard of labor analgesia, says the ACOG guidelines. With neuraxial labor analgesia, there is dramatic and consistent analgesia. There is effective participation of the parturient in the birthing experience. Studies have proven the safety for both the mother and the baby, and there is feasibility of conversion in case it is converted into an operative delivery. The most important indication for neuraxial analgesia is maternal request. Early placement of epidural catheter is recommended in those with high chances of surgical delivery, also in patients with high BMI and patients with difficult airway. It is also recommended in medical conditions benefiting from reducing the stress of labor, like hypertensive disorders of pregnancy, when there is fetal well-being compromise, or when there is severe cardiorespiratory disease in the mother. The absolute contraindications for neuraxial analgesia are few. One is maternal refusal, one is untreated shock and increased ICP. Talking about coagulopathy, most consultants are comfortable placing an epidural when the platelet count is above 75,000. When the count is below 50,000, we differ from giving an epidural. And when the platelet count is above 50,000 and all other coagulation parameters are normal, it is acceptable to go ahead with a labor epidural. Talking about low molecular weight heparin, if the patient is on once daily dose, a gap of 12 hours, and for twice daily dose or a VD dose, a gap of 24 hours is recommended before citing an epidural. These are most common queries that we come across from patients and relatives as well as the obstetricians about the safety of a labor epidural. Studies have proven that it is safe for both the mother and the fetus, and backache, if any, is transient and usually resolves within a week. And how to answer the obstetrician's questions. In literature, there are contradictory reports about the duration of first stage with neuraxial block. This is a study done in our institution, and the data revealed that first stage was significantly prolonged in patients with epidural analgesia without any deleterious effect on the mother and the fetus. Between the epidural and non-epidural groups, cesarean rates were also significantly lower in the epidural group, while instrumental deliveries were higher, and spontaneous vaginal deliveries remained the same. One of the probable reasons for more instrumental vaginal deliveries in the epidural group was as patients with difficult labor opt for neuraxial analgesia, or that it is easier to perform assisted vaginal deliveries in a relaxed, pain-free patient. Newer evidence from RCTs and meta-analysis in 2017 shows that there is no significant difference between the duration of first or second stage of labor, the rate of instrumental birth, cesarean delivery, or spontaneous vaginal delivery in patients who take epidural or compared to patients who do not take epidurals. In institutions providing 24-hour labor analgesia services, it is recommended that the patient be attended to by the anesthesiologist within 30 minutes of labor analgesia request. A good teamwork involving the obstetrician, anesthesiologist, and neonatologist is necessary. We have to ensure the availability of monitoring and resuscitation equipments for both the mother and the baby. A point to note is that co-loading of fluids and anti-aspiration prophylaxis isn't necessary. We encourage the parturian to take clear fluids throughout labor. After obtaining an informed consent, the epidural can be placed either in the lateral decubitus position or in the sitting position. This is a picture of one of our staff who's comfortably sleeping in the labor suit after a labor epidural. You can see the setup. You can see the labor suit with resuscitation equipments for the patient as well as continuous fetal CTG monitoring. Let's talk about an epidural test dose. With conventional test dose, 3 ml of 1.5% lignocaine with 1 in 200,000 adrenaline was given to the patient. If the catheter was accidentally placed intravascularly, this would increase the heart rate and SBP by more than 20% from the baseline within 1 minute. And if the catheter was placed intrathecally, this would cause an onset of sensory block within 3 minutes or motor block within 5 minutes. Now we know that this conventional epidural test dose is not 100% safe, sensitive, or specific. false positive values can happen. There can be increased heart rate due to physiological response to pain, as with uterine contractions. In patients who are hypertensive, if this dose goes intravascularly, there can be profound hypertension and also decrease in uteroplacental flow, which can cause fetal compromise. And if this test dose goes intrathecally, this can cause a high spinal. So do we have any alternatives to your conventional test dose? First thing to remember is that every dose is considered a test dose. Aspiration for blood and CSF at insertion and prior to each top-up is mandatory. Every injection should be considered a test dose and should not exceed 5 ml aliquots of dilute local anesthetic. Using dilute local anesthetics reduce the total dose of local anesthetic if inadvertent intravascular or intrathecal placement of the epidural occurs. Presence of flexible soft epidural catheters now reduce the risk of venous cannulation, and if you're ever in doubt, don't hesitate to replace the catheter. Epidural maintenance can be done by the following modalities. A word about adjuvants. Other than fentanyl, clonidine and dexmedetomidine has been studied with various labor analgesics, and it is said to decrease nausea, pruritus, and vomiting as compared to opioids, but this is still off-label for use in labor analgesia. Coming to single-shot spinal analgesia. It causes rapid, reliable, and short-duration analgesia. This can be given with either fentanyl alone or fentanyl with low doses of hyperbaric bupivacaine. Indications are when you're called in advanced labor, or there has been an accidental dural puncture, or in difficult anatomy like post-spinal surgery or in morbid obesity. The complications usually are fetal bradycardia, pruritus, nausea and vomiting, which is all due to the opioid component in the spinal compartment. Continuous spinal analgesia is never the first choice because of fear of post-dural puncture headache, cauda equina syndrome, and infections. If instituted, it gives rapid, prolonged, and reliable analgesia, which can be converted to surgical anesthesia if necessary. The solutions we use are similar to that in epidural infusions. A point I would like you to remember is that while we use more dilute solutions, you can bring the rate up to 3 ml per hour. But if you're using more concentrated solutions like 0.1% bupivacaine or ropivacaine, the solution should be, the rate of infusion should be decreased to 1 ml per hour. The indications and complications remain similar to single shot spinal. Also, another important point is that the labeling of the catheter should be spinal. And every person who is involved in the care of the person should know that it is not a labor epidural, but a continuous spinal analgesic catheter. For that reason, there will be no demand boluses or patient control boluses allowed with continuous spinal analgesia. Now, Payunk has come out with a Sprotty needle with a dedicated catheter for continuous spinal analgesia or anesthesia. Coming to combined spinal epidural, this is a technique which involves benefits from both spinal and epidural technique. This can either be given as a needle through needle technique or by putting two different needles in two interspaces. The spinal component again is by use of opioid alone or with low dose of hyperbaric bupivacaine, which causes rapid onset short duration analgesia, after which the epidural can be topped up like in a conventional epidural infusion. Indications are when you are approached for an epidural and late established labor or when there is fast progression of labor. In comparison to a conventional epidural, with a CSE, there is quicker onset and superior analgesia. There is less sacral sparing and higher maternal satisfaction. One disadvantage is that the epidural cannot be tested until the spinal analgesia wears off. Dural puncture epidural has been in vogue for the past couple of years. and it is nothing other than a CSE without injection of subarachnoid drugs. As you can see in the picture, like in a CSE, when the spinal needle encounters CSF, the needle is withdrawn without depositing any drug in the subarachnoid space. There is better analgesia because of epidural drug leaking into the subarachnoid space. This again, in comparison to conventional epidurals, are more rapid, superior, and symmetric analgesics, especially there is less sacral sparing. Also, it is found that when you use a 25 gauge spinal needle, it gives more superior analgesia to using a 27 gauge for DPE. What is a walking epidural? This is when an epidural or CSE is given with a low dose local anesthetic and opioid combination, where the motor function is preserved while relieving pain. Even though it is called a walking epidural, majority of patients do not want to ambulate, but they are free to move around in the bed, and maternal expulsive efforts are still preserved. After depositing the drug, the patient is made to lie in bed, following which low-risk mothers with low-risk fetuses are encouraged to ambulate when they have accompanying attendant. Initially, you check for the motor, sensory, and autonomic blockade. Make sure there is no postural hypotension. And after the patient can take 6 unassisted steps, they are encouraged to ambulate if they want to. When you have an obese patient with a back like this, the newer devices like ultrasound and acoustic puncture assist device helps you in identifying the epidural space. Now we'll come to the regimes that are used in neuraxial analgesia. A point that I want to stress is that a larger volume of a more dilute agent is more effective for labor analgesia than a smaller volume of higher concentration. The dose regimens are shown in the slide. In our institution, what we practice is mostly a conventional epidural with a conventional epidural infusion. So the initial bolus after siting the epidural is mostly 10 ml boluses, which is given as 5 ml aliquots of 0.125% or 0.2% ropivacaine with 2 mics per ml fentanyl. After this, the patient is assessed for sensory block, and if adequate, a maintenance infusion of more dilute solutions like 0.0625% bupivacaine or 0.1% ropivacaine with 1 mic per ml fentanyl is given as 5 to 10 ml per hour infusion. When the patient experiences breakthrough pain or during the second stage, we give bolus of 5 ml with a more concentrated solution in the sitting position or propped up position, and the mother is made to sit like that for 5 to 10 minutes till there is adequate pain relief. With conventional epidural, there were gaps in achieving adequate pain relief. This led to the development of newer modalities that preserved motor function with better analgesia. So came the programmed intermittent epidural boluses or the PIEB pumps and computer integrated PCAA pumps. Slow continuous infusion with low injection pressure causes drug to exit almost exclusively through the most proximal hole of a multi-orifice catheter, limiting the spread of local anesthetic, as is seen in conventional epidural infusions. Then came the PIEB pumps, where bolus injections with greater injection pressures allow drug exits from all holes of the multi-orifice catheter, which leads to more spread of the local anesthetic. So this was the thought behind developing a PIEB pump. Here, automated administration of epidural solutions as fixed boluses at scheduled intervals is given. Greater sensory dermatomal spread with less motor blockade has resulted when compared to our conventional epidural infusions. There are pumps that have PIEB in association with PCEA, which leads to more maternal satisfaction and less physician interventions. These are the various settings that you have to set in a PIEB pump. Coming to computer integrated PCA pumps, it automatically adjusts background infusion rate based on the number of PCA demands in the previous hour. Continually, it records patient analgesic requirements. If there are an increased number of PCA boluses in the previous hour, the basal infusion rate is automatically increased by the computer. If there is no PCA bolus requirement in the previous hour, the dose is automatically de-escalated. Now let's come to troubleshooting with epidurals. By definition, neuraxial analgesia failure is inadequate analgesia in spite of adequate dosing. Inadvertent dural puncture, intravascular placement, or requirement of replacement of catheter or alternative pain management is also neuraxial failure. We need to reassure the patient, and the pain could be due to advancement of labor, catheter-related problems, or inadequate dosing. In case of inadequate dosing, this will be evident by sensory levels less than T10 bilaterally. And if the pain is mild, what we do is we can give larger volumes of dilute local anesthetic. If the patient pain is moderate to severe, we have to consider more concentrated local anesthetic. The pain is unilateral, the patient is made to lie lateral and a more concentrated solution is given and they rest for 5 to 10 minutes, following which there will be adequate pain relief. In second stage, patient is propped up and a more concentrated local anesthetic is given. In CSE, after the spinal component has worn off, the epidural is topped up like in conventional epidural. A thing to note is that labor analgesia does not mask pain due to uterine scar rupture. Now, how do you remedy the catheter-related problems? You have to first look at the site of catheter insertion. If the catheter has moved out, you have to replace it. If it has moved in, it may be into the subcutaneous tissue and you don't need to worry. After giving 2 unscheduled top-ups, if their pain still remains, you should consider replacing the catheter. If you see the catheter and it is still properly positioned, then textbooks recommend the use of 3 to 5 ml of 2% lignocaine. And if there is no motor or sensory block, we should replace the catheter. Now, how do you dose after replacing a catheter? If there was only minimal sensory and motor block with the initial epidural, a full epidural loading dose can be given. If there is partial sensory and motor block, only top-ups can be given and you have to reassess the patient for adequate pain relief. The dictum is do not hesitate remedying. If there is accidental dural puncture, and this happens in advanced labor, you can convert it into a single shot spinal. If it is in early labor, you can either convert it into a CSE or put an epidural at a different position. The thing to remember is you've made a large hole with your 2E needle. So your epidural, local anesthetic bolus dose and basal infusion should be reduced because there is high chance of exaggerated response. Complications that are seen. Hypotension is very uncommon because we use dilute concentration of local anesthetic with opioid. PDPH is almost a sure entity if you have advertently punctured the dura. Textbooks recommend the use of 1 to 1.5 liters of saline in the epidural space to decrease PDPH. Maternal hyperthermia, usually less than 38 degrees, also seen with labor epidurals. This is said to be of non-infectious nature. This may be because of inflammatory response or change in thermoregulation. Opioid-related fetal bradycardia, pruritus, nausea, and vomiting may occur. In our labor suit, patients are only allowed out after they have passed urine. Backache may be transient, which spontaneously resolves. Nerve damage is seen in less than 5% of patients. Epidural hematoma and infections are rare occurrences. These are the ongoing studies in our department with dural puncture epidural. And the latest one is the use of program intermittent epidural boluses versus conventional epidurals. To summarize, labor analgesia is a woman's right. Labor epidural is the gold standard. Low dose local anesthetic with opioids is the norm and it involves good teamwork. These are my references. Thank you.
Thank you, Dr. Shalini ma'am. It was really very Thank you for the insightful and engaging lecture. It was truly a valuable learning experience. I'm sure not only for the PGs, but also everyone who want to practice labor analgesia. So there are few questions I think we can take, and before proceeding further, I request Dr. Archita to kindly read this question for Dr. Shalini.
Ma'am, the first question is, do only platelets have any bearing on the placement of the epidural, or other coagulation profile parameters also considered?
Usually in our labor suits, we don't usually check the coagulation parameters unless it is indicated, like in a patient who has got hypertensive disorders of pregnancy. And textbooks say that if the platelet count is above 1 lakh, you don't actually need to see the coagulation parameters. But as a dictum, what we do is, if the patient has BP of 140 over 90 or more, we repeat the PIH profile, and we do look for coagulation parameters just in indicated patients.
Okay. Thank you, ma'am. The next question is, what is the role of dexmedetomidine or clonidine in labor analgesia?
In literature, they say 15 mics of clonidine has been used, but it is associated with fetal bradycardia. Dexmedetomidine in different concentrations are also tried, but this is all off-label for labor analgesia, so we do not use it. We only use fentanyl.
Yes, ma'am. Is continuous spinal with a catheter safe option? Is what
in our institution, we
Naini
don't
has asked.
practice it because there is fear of infection and the chance of the level ascending, and also fear of using epidural boluses by accident in that catheter. So we usually do not practice continuous spinal analgesia.
Yes, yes, ma'am. Is there any role of the anesthetist interacting with the parturients or the patients, even in the ANC time? Is what
I actually had more slides. I didn't want to exhaust you. We have regular antenatal classes every month, along with obstetricians and neonatologists for third trimester patients and their relatives, where we have video presentations and presentations on from both sides. We tell them about different modalities of labor analgesia, and we talk to them and allay their fears, and we leave them with a pamphlet, which is in regional language as well as in English, talking about when they can take it, the safety and the complications and everything.
Right, ma'am. That is a very good initiative. And since you have been in this field for so many years, I think your experience is helping all of us to take forward new ideas to our patients.
Thank you.
I think, Archita, we can go for the next part. That is our case discussion. And I request Professor Dr. Shalu ma'am to kindly proceed further with me. Rest, we can take questions after this case discussion, I think.
Now we move on to case discussion. Welcome our postgraduate students, Dr. Princey and Dr. Albin, to join us.
Thank you, ma'am.
Labor pain, as we have seen, is described as most excruciating pain as far as Magill's pain scale index is concerned. And we have also decided that it does not serve any useful purpose. So we have decided on labor pain being addressed. So we'll start with what is the pain pathway involved in labor pain?
So in the early first stage, labor pain is a dull, aching, visceral pain, mainly due to the contraction of the uterus and cervical dilatation. This is mainly transmitted by the A delta and C fibers to T10 and L1 level. The pain becomes more severe in the late first stage, and in the second stage, there is additional somatic pain during the perineal stretch by the presenting part. Here, the pain is carried by the carried to the S2 to S4 spinal nerve. The late first stage and second stage is more painful. So, during this period, we have to block from T10 to S4 level.
Now, between the pharmacological and non-pharmacological methods, neuraxial block, especially epidural, is considered the gold standard. And also, that is when the anesthesiologist really comes in the picture. So here we have a patient, 25-year-old primate, 38 weeks of gestation, no comorbidities, is in labor, and there is a request for epidural analgesia. Pulse rate is 88 per minute, BP is 100/70. PV finding shows cervix 3 centimeters long and 3 centimeter dilated, vertex at -3 station. How are you going to proceed with epidural analgesia?
As per the recommendation by ASA and ACOG, a maternal request is sufficient indication for providing a labor analgesia. So, if we can provide the labor analgesia regardless of the parity of the patient, whether the patient is in first stage or second stage of labor or the fetal station. One thing we have to be ensure is that a good teamwork involving the obstetrician, anesthesiologist, and neonatologist, which is essential. And prior to the labor analgesia, we have to go for a thorough pre-anesthetic evaluation. This will include the antenatal history, past medical, surgical, and treatment history. Blood investigation has to be looked for. And after that, we will obtain an informed consent from the mother after explaining the procedure and the complications. Prior administering the labor epidural, we have to ensure the availability of resuscitation and monitoring equipments for both the mother and fetus. Emergency drugs has to be kept ready, and we have to go with the continuous CTG monitoring of the fetus. After attaching the standard monitors and the trained professional for the continuous monitoring, we can go ahead with the labor analgesia. We usually avoid loading, but we have to make sure that the patient has taken enough clear fluids during the period, and anti-aspiration prophylaxis is not that mandatory. The position we preferred is the left lateral position while administering the labor epidural. It is preferred because it has a less risk of having hypotension, syncopal attacks, and more acceptable by the mother compared to a sitting position. And under aseptic proportion, you usually puncture, we will go for the epidural catheter placement at L3, L4 level. And the catheter is threaded in the caudal direction. And you have to fix a 3 centimeter epidural space in case of a normal patient and 5 centimeter in case of an obese patient. The epidural catheter should be fixed properly and marked at the site. The site at the skin is marked and documented. After the procedure, the patient is placed in supine position with 15-degree tilt to the left side. In our institution, what we follow is a 10 ml bolus of bupivacaine 0.125% or ropivacaine 0.2% with fentanyl 50 to 100 mcg in 5 ml aliquots, which is then followed with a continuous epidural with 0.0625% bupivacaine or 0.1% ropivacaine with 1 to 2 mcg per ml fentanyl.
Sorry to interrupt, but the PGs, if you can talk little loudly because you're not very clearly audible.
You'll try, ma'am.
I heard you say that you will take consent from the mother.
Yes,
Is consent from the mother alone enough to give epidural analgesia?
What we know that the consent from mother is enough for a labor epidural analgesia, but in our institution we are also getting consent from the bystanders also for us as a witness.
Actually, our problem is getting consent from the mother-in-law, which is the most difficult. So actually, theoretically, only consent from the patient is enough. Okay. Now, how do you confirm epidural space?
Epidural space can be confirmed the standard loss of resistance technique, which we are usually used in case of an epidural while administering epidural. But this identification of space in a pregnant woman is difficult because of the hormonal, because of the laxity of ligament due to the hormonal changes, and the narrow epidural space because of the dilated epidural veins, and because of the increasing lumbar lordosis. Next method to confirm the epidural space is the conventional test dose. That is, the recommended conventional test dose is injection lignocaine 1.5% with adrenaline 1 in 2 lakh concentration. So if the catheter is intravascular, we have expecting an increase in the heart rate and systolic BP by 20 or 20% above the baseline. Intrathecal placement would result in sensory block in 3 minutes and motor block in 5 minutes. But in case of a labor analgesia, the specificity, sensitivity, and safety of this conventional dose is a debatable thing. So it is because while we are testing for the intravascular placement of the epidural catheter in a laboring patient, increase in heart rate and systolic BP can also be due to the physiological response to pain. This result in a false positive interpretation, leading to the unnecessary removal of the catheter or reinstrumentation. Another thing is, while we are administering an adrenaline intravascularly, it can cause the vasoconstriction of the uterine vessels, and which can lead to the decrease in the placental circulation. And it also relaxes the uterus and slow down the labor. In case of patient with a PIH, that intravascular adrenaline can cause profound hypertension. In case of testing for the intrathecal placement, high concentration of local anesthetic can cause high motor block. So what we have to be kept in mind that aspirate for blood and CSF at the insertion and prior to each top-up dose, and every injection should be considered as a test dose, and we will give it as a 5 ml aliquots. And we can use low doses of dilute local anesthetic, that is 0.065% bupivacaine or 0.1% ropivacaine. And by using a flexible soft epidural catheter, also decrease the risk of intravenous cannulation.
Now your epidural labor analgesia is going, and you're summoned to the labor room to manage breakthrough pain for this patient. And how are you going to manage this case?
Breakthrough pain can happen because of advancement of labor, or if there is inadequate analgesia, or due to any catheter-related problems. So for inadequate analgesia itself is defined as neuraxial analgesia failure due to in spite of adequate dosing, or there is need of any alternative pain management. So inadequate dosing will be indicated by bilateral sensory level of less than T10. So if the patient complains of mild pain with low sensory level, we can top up with a higher volume of drug of dilute solution. But if the patient complains of moderate to severe pain, consider shifting it to a high concentrated drug. And if the patient complains of unilateral pain, consider keeping the patient in a lateral position with painful side towards it down, and top up with we can give bolus dose. But if the patient complains of breakthrough pain in second stage of labor, additional bolus of concentrated drug can be given by keeping the patient in proper position and maintain the position for 5 to 10 pain, because this pain can be because of perineal somatic pain. And the other causes for breakthrough pain is catheter-related problems. It can be either because catheter has moved out, or because of subdural placement of catheter, or because of the catheter has gone through intervertebral space. So for catheter problems, we should first inspect the catheter to see whether there is any kink in the catheter, and we should inspect the mark at which it is fixed, whether to consider whether it has moved out or not. So, and consider replacing catheter if it has moved out, or any two unscheduled top-ups has not provided adequate pain relief.
Now, having done all this, you're not successful. And when do you decide that you have to replace the epidural catheter?
Ma'am, epidural catheter can be considered to be replaced if it has totally moved out or displaced from the mark at which we have fixed it, or two unscheduled top-ups have not provided enough analgesia. It can also be considered to replace if there is unilateral pain, and for that we have administered the concentrated drug in lateral position and waited for 20 minutes for adequate pain relief. If that's not happening, we can consider to replace the catheter. We can also consider to replace catheter if there is catheter is appropriately placed and there is sensory and motor block are equivocal, but there is no pain relief. So alternative suggested is administering 3 to 5 ml of 2% lignocaine it should produce sensory and motor block. So if these blocks are not there, we can consider replacing the catheter. So if there is if after this thing, after replacing the catheter, if the patient has only minimal sensory or motor block, we can give the full loading epidural doses after the replacement, and only the top-up dose and reassessment is needed in case of any partial sensory or motor block.
So in the other words, the message is, if your pain relief is inadequate, don't hesitate to replace the catheter. Okay. And the next is, while attempting epidural analgesia, accidental dural puncture occurred. What are your options for management?
If the accidental dural puncture occurs in the advanced labor, a single shot of spinal with a 0.5 ml of hyperbaric solution, that is that can be 2.5 milligram of hyperbaric bupivacaine with 25 mcg of fentanyl can be given, as this analgesia will last for 1.5 hours or more. But if the accidental dural puncture occurs in early stage of labor,
Okay, you are not audible. Can you?
If this accidental dural puncture occurs in advanced stage of labor, a single shot spinal can be given, which with 0.5 ml of hyperbaric bupivacaine, which will be 2.5 milligram of hyperbaric bupivacaine, and with opioid of 20 mcg fentanyl, which can be given, and the analgesia will last for 1.5 hours or more. But if this if accidental dural puncture is occurring in early stage of labor, one option is to make it a combined spinal epidural with giving hyperbaric local anesthetic into the subarachnoid space and putting an epidural catheter through other space. The second option is continuing with epidural analgesia by placing an epidural catheter from other space. And the third option is the one of continuous spinal analgesia by placing the catheter, epidural catheter in the subarachnoid space. But we don't practice this routinely in our institution because of its possible hazards.
Now, what has happened is you have punctured the dural, gone into the subarachnoid space with the big epidural 2E needle. Now, with these needles, when this happens, what is the thing which we should stress on? What is the dosing and things should be?
Ma'am, we should stress on the exaggerated response of the initial bolus and the basal infusion rate at which we are giving the epidural analgesia, because it can go into the subarachnoid space and can cause the exaggerated response of the local anesthetic which we are giving.
In other words, some of the drug can leak into the subarachnoid space. So that is why you are worried. And so you should stress on coming down on the doses till you are settled. What is prolonged second stage by definition?
As per the definition by the ACOG, prolonged second stage, in case of a nulliparous woman, it is more than 2 hours if the patient is having no neuraxial block, and is more than 3 hours in those with neuraxial block. Whereas in case of a multiparous woman, it is more than 1 hour and more than 2 hours respectively.
Now, in the second stage of labor, your obstetrician has decided on an instrumental delivery. How are you going to manage the situation?
So the late first stage and the second stage is considered to be the most painful period. So our goal is to provide an adequate analgesia, but we have to maintain the ability to push for the delivery of the baby. So once the second stage begins, there is a perineal somatic pain. So we will give an additional top-up of the drug, usually in the propped up position, and the patient has to be maintained that position for 5 to 10 minutes. This will relieve the perineal somatic pain in the second stage. If the obstetrician want to go for a forceps delivery, which is very painful, this requires an additional concentrated epidural bolus, 5 to 10 ml of 1 to 2% lignocaine or 0.125% bupivacaine or 0.2% ropivacaine. Vacuum delivery is comparatively less painful, which can be managed with the diluted local anesthetic, which we are already using for a continuous infusion. And if the patient has no epidural or the epidural working is not working well, we can go with a single shot spinal or a pudendal nerve block.
There is poor progress. You are called for labor analgesia when the patient is in advanced labor. We get such calls often. And what are the options you have for giving analgesia?
So, if the patient is called, if we are called for a labor analgesia in the advanced stage of labor, first, if the delivery is imminent and there is no time for the establishment of an epidural block, we can go with the single shot spinal analgesia, usually with a combination of the hyperbaric local anesthetic with fentanyl. By giving a single shot spinal analgesia, it has a faster onset of action and it relieves the pain immediately and provide intense sensory block. And there is relaxation of the pelvic floor muscle, and it also provides postpartum analgesia. And if the delivery is not that imminent, we can go with a combined spinal epidural, where we will give intrathecal fentanyl with hyperbaric local anesthetic along with opioid, which provide a rapid onset of action and an excellent analgesia. This can be followed up with the epidural analgesia.
There is poor progression of labor in this patient. Obstetrician has posted her for an emergency LSES. How do you manage?
So, a pregnant lady is having a high risk for aspiration. So, we will go first with the anti-aspiration prophylaxis. In our institution, we are giving injection ranitidine 50 milligram and injection metoclopramide 10 milligram IV. Then we will prepare the operation room for an emergency LSES at an ambient temperature with properly checked anesthesia workstation, backup ventilation, working suction apparatus, then intubation cart, neonatal resuscitation trolley. All the anesthetic drugs, emergency drugs, and uterotonics are loaded and kept ready. And with the patient with an indwelling epidural catheter for a labor analgesia is usually transported with caution because we have to avoid the displacement of the epidural catheter. And usually the patient is transported in the left lateral position with the standard monitors attached. And in the theater, we will position the patient in a supine degree with 15-degree left uterine displacement. After that, we will call out the patient with a 500 ml of balanced salt solution. And after confirming the epidural catheter in position and negative aspiration for blood and CSF, we first administer a 3 ml of injection lignocaine, 2% with 1 in 2 lakh concentration of adrenaline as a test dose. Then it is followed up with 12 to 15 ml of lignocaine, 2% with adrenaline or 0.5% bupivacaine or 0.75% ropivacaine. This drug can be given alone or in combinations till we achieve a sensory level of T6 level.
So you have decided that it is mandatory to give the conventional test dose when you're proceeding with anesthesia. Is that right?
Yes, ma'am.
Okay. Now you get a call saying that the patient has got a slowing of fetal heart rate and is posted for emergency LSES. How fetal distress is the indication, and how are you going to manage this patient?
The initial part, that is the anti-aspiration prophylaxis, and the shifting of the patient is done as we are already done in the normal other patient also. In the OR, after positioning the patient in supine with 15-degree left uterine displacement, I will ask the surgeon and other OT personnel to prepare for the surgery and paint and the patient. In the meanwhile, I will try to top up the epidural analgesia with the same dose as we are normally using, with the backup of general anesthesia. Drugs are kept ready.
So I think we can manage because it takes at least by 10 minutes you should be ready with the patient all ready for cesarean. That at least that much time the obstetrician will take to get ready for putting the incision, draping and all that. So topping up the epidural is a possibility even in fetal distress because the general anesthesia is thought to be more detrimental to the baby. Now you have another case scenario. This is a 35-year-old second gravida with hypertension on tab nicardia and tab labetalol at 35 plus 2 days of gestation in labor. Patient is on aspirin 150 milligram OD. Platelet count is 75,000, INR 1.2, and there is no history of bleeding. She requests for labor analgesia. My question is, can you go ahead with epidural analgesia? If so, what are the benefits of labor analgesia in this patient?
Ma'am, Neuraxial and central Neuraxial analgesia will be considered safe in this patient as the platelet count is 75,000 and the INR is 1.2 and there is history of no ongoing bleeding. So a platelet count of 1 lakh is considered safe, and in less than 50,000 we defer giving central Neuraxial analgesia. And if the platelet counts are above 50,000 and other coagulation parameters are normal and there is no decreasing trend in coagulation parameter, or if there is no evidence of DIC, we can proceed with epidural analgesia. And labor analgesia will be beneficial in this patient, particularly since labor pain can cause sympathetic stimulation and it can cause catecholamines and other hormones release, which can exaggerate the hypertension. So this will result in ultimately this will result in reduced uteroplacental circulation, and there will be decreased uterine contraction, and maternal fetal acidosis can happen. So labor analgesia will be beneficial for this patient by subsiding the sympathetic stimulation.
Now you have a 26-year-old Phryne who's a known case of mitral stenosis at 36 weeks, and she's in labor. She's on beta blockers and low molecular weight heparin. On examination, she's in AF, atrial fibrillation with a controlled ventricular rate of 74 per minute, blood pressure of 110 over 60 millimeters of mercury, regular respiration with an SpO2 of 95% in room air. Echo shows moderate mitral stenosis and ejection fraction of 45%. Patient is requesting labor analgesia. My question is, do you recommend epidural analgesia for this patient? If so, what are your concerns?
Early institution of epidural analgesia will be recommended in this patient because, as we discussed, it can decrease the sympathetic stimulation by the labor pain. And the parturients with the MS are at risk of developing hemodynamic compromise and pulmonary edema, both intrapartum and postpartum. So the advantage of labor epidural will be it will attenuate the increase in heart rate and cardiac output with minimal change in the systemic vascular system, so that hypertension cannot occur. And it will also increase the venous capacitance to accommodate the autotransfused blood during uterine contraction and after delivery. So the preferred choice will be epidural analgesia with a low dose of anesthetic, local anesthetic with opioid can be given. And but the second stage of labor should be shortened by vacuum or forceps delivery in order to avoid the exertion fatigue or the detrimental effect of Valsalva maneuver. So the adequate pain relief should be assessed in the second stage also. For low molecular weight heparin, as per ASRA guidelines, the low molecular weight heparin in OD dose, that is prophylactic dose, a gap of 12 hours should be maintained for before proceeding to central neuraxial blocks. And for therapeutic doses, a gap of 24 hours is recommended before proceeding to central neuraxial block. And abstinence of 12 hours of low molecular weight heparin is needed before the catheter removal in OD dose, and indwelling catheters are not recommended when it is given in BD dose. Low molecular weight heparin can be restarted after 4 hours after the catheter removal.
So in our institution, there has been many patients over the years who have had mitral stenosis, mild to moderate, and some patients have actually, I think 2 or 3 have presented with pulmonary edema, and it has been successfully managed with a labor epidural and with help from our cardiologists as well as our obstetricians and neonatologists.
30-year-old primate with BMI 40 kilogram per meter square at 37 weeks comes in labor with leaking per vagina. She is getting regular contractions lasting for 10 to 15 seconds in 10 to 15 minutes interval. Antenatal period was uneventful. Obstetrician decided to have an epidural analgesia started early. How do you manage?
A BMI of more 40 kilogram per meter square belongs to class 3 obesity. So for this patient, early placement of the epidural catheter is beneficial. Prior to the institution of the labor epidural, we have to assess the patient for obstetric sleep apnea syndrome, along the signs, complications like any decreased functional capacity, increase in the blood pressure, any signs of right and left ventricular hypertrophy, arrhythmias, any evidence of pulmonary hypertension, diabetes, has to be assessed and should be managed. And the concerns include while positioning of a patient, we will prefer for a sitting position with leaning forward. This facilitates the identification of the midline. Lateral position is not preferred because of the gravity, the lateral fat may be sagged down, which can obscure the midline. And the palpation of the spine may be difficult in this patient. So we can use for ultrasound guided to identify the epidural space. Sometimes we may require a long epidural needle because of the greater depth of the epidural space. And there is, in some patient, we will get a false loss of resistance or increased risk of having unintentional dural puncture. This is mainly because of the presence of fat pockets and hormonal laxity of the ligament, which make the difficulty in identification of the loss of resistance. And one thing we have to be cautious in this patient is we have to keep the catheter at least 5 centimeter in the epidural space to avoid the displacement. And the epidural catheter has to be well fixed, and if needed, we can even tunnel the catheter into the skin to avoid the displacement.
Who are the patients in whom early epidural catheter placement is recommended?
Early epidural placement can be done if we are anticipating a high chance of surgery, as in case of a multiple pregnancy in unfavorable position. If the patient have a previous history of postpartum hemorrhage in the previous pregnancy, or the patient have a BMI more than 40 kilogram per meter square and anticipate a difficult airway, or if the patient gives history of malignant hyperpyrexia.
What is dural puncture epidural?
Dural puncture epidural, here we will, it is similar to combined spinal epidural, where dura is punctured, but once the CSF is seen, the spinal needle is withdrawn, and the injecting, we did not inject the drug into the intrathecal space. Then we will thread the epidural catheter into the epidural space, and analgesia is initiated as in conventional epidural technique. It has a rapid onset of action, superior and symmetric analgesia. It also provides sacral analgesia when compared to the conventional epidural. The mechanism is because of the rent in the dura, there is leakage of the drug from the epidural space to the subarachnoid space, leading to improvement of the analgesia.
You have heard of walking epidurals. What is walking epidural?
Walking epidural is epidural or combined spinal epidural with a low dose of local anesthetic and opioids. Its advantage is that it preserves the motor function while relieving the labor pain. So it allows the patient to move freely in the bed and to also ambulate if desired, while the expulsive efforts of the patients are preserved. And ambulation of the patient is always like the patient should always be assist with the attendants. They are not allowed to ambulate by themselves.
So actually, walking epidural, you have heard that 85% of the patients do not wish to ambulate. More important than patient walking around, it is that the patient can move freely around in the bed, push effectively, and all that is what is most important.
What is continuous spinal analgesia?
Continuous spinal analgesia is which we place an epidural catheter or a 28 gauge microcatheter in the subarachnoid space, and and we will give a combination of local anesthetic and opioid as a continuous infusion. Usually, we can go with a 0.0625 to 0.1% bupivacaine along with 2 mcg per fentanyl, or a ropivacaine 0.08 to 0.1% with 2 mcg per ml fentanyl. But the infusion rates are low. If we are using a higher concentration, we will go with a 1 ml per hour infusion. And if the lower concentration drug is used, we can go with 3 ml per hour infusion. One thing we have to keep in mind is we will avoid the demand boluses and also patient control boluses. The routine administration is we will differ because there are increased risk of having PDPH, any coda equina syndrome, fear of infections.
So it is not preferred to be used routinely.
Yes, no, routinely.
That brings us to the end of the questions we have. Ma'am, can we address the questions in the chat box?
Thank you, ma'am. I must congratulate Dr. Princey and Elvin. I think they have really stood good, and it's all the credit goes to madam. I would like to express my sincere thanks for the enlightening discussion. Your expertise and guidance are truly appreciated, madam, and it's incredible informative. Now I request Dr. Archita, please take few questions.
Yes, ma'am. Some of the questions are repeat from what we had discussed during your presentation, so we won't take those. There is one which says that if the patient complains of pain and unilateral blockade, which is not relieved even by giving doses in the lateral position, what would be our next action?
We will go for replacing the catheter.
How long do you wait? What do you do? What is the remedial method you try? And how long do you wait to see if it is effective? And then what will you do? If it is not effective, then what will you do?
We'll consider patient in lateral position and give top up with the we'll give the bolus dose and we'll wait for 20 minutes to look for any pain relief. If not, we can consider a replacement of the epidural catheter.
What solution do you give? Is it dilute solution or concentrated solution?
We can consider concentrated solutions.
And the lateral position with the painful side?
Painful side towards the downside.
Okay.
The next question that follows is, in spite of redoing and placing the epidural second time, if still there is unilateral blockade, what would be our what would be the causative factor and how would we relieve it?
It may be due to the position of the presenting part. In posterior position, there is because of the sacral sparing can occur.
Be a little louder, Princey and Alvin.
It may be due to the sacral sparing which is occurring. So we will try for a higher concentrated dose or increasing the infusion rate. And if then also the pain is not relieving, we can go with other pharmacological systemic methods.
Do we need to go with systemic methods or reinsert an epidural? And maybe giving a spinal component will help decrease the sacral sparing.
Other two occasions when it does not become effective is one, they have written up about compartments in the epidural space, which may be a cause. Another problem is when you have occipito-posterior position for the baby. It is one of the conditions where we find it difficult to make the analgesia very effective.
The one way we can make out occipital posterior position with labor epidural is they keep asking for top up. Also, early on in labor, even with inefficient cervical dilatation, there is rectal pressure. Early on in labor, they would want to bear down. So that is something that I have seen with occipital posterior positions.
And of course, it doesn't become effective. You should try other things like paracetamol, as well, like Dr. Shalini said, a Spinal might help, and sub-anesthetic doses of ketamine, uh, and IM injections of drugs. Anyway, whatever is up our sleeve, we have to try to alleviate the pain.
Okay, the next question is, ma'am, when is the epidural catheter removed post-delivery?
Post-delivery, after they have done up the episiotomy, the catheter is removed. In our institution, the practice is that the woman is only allowed out of the labor suit after she has passed urine. And you're able to ambulate on your own.
Okay.
There is a question about indwelling spinal catheters in BD dose, low molecular weight heparin. Even epidural with BD dose or therapeutic doses of low molecular weight heparin, indwelling catheters are not recommended.
So if at all you put in an epidural with the BD dose, when you're putting it, you have put it after 24 hours. So immediately after the analgesia bit is over, you have to remove the catheter because you need at least 24 hours gap before you can take out the catheter. So this was put in after 24 hours gap, so it can be easily removed at the end of the procedure, because indwelling catheters are not recommended as per ASRA guidelines in BD doses.
Okay. Ma'am, there is a question on the role of inhalational agents in labor analgesia, whether they are used or they are not.
We used to have Entonox at a time, but we give so many labor epidurals, and labor epidural practices has been going on since 94. So somehow they say there is inferior analgesia. And with Entonox, because our labor suits don't have scavenging, there is also the concern of the patient as well as related personnel inhaling nitrous oxide and environmental concerns because of ozone layer depletion and such.
Right. There's no role of any other inhalational agents like sevoflurane or routinely that we use.
We don't use
No.
it, but sevoflurane is oxygen and sevoflurane. It's also
Okay.
said to be good.
Okay. There's one question to just reiterate the drugs and dosages of local anesthetic in walking epidural, which you have already covered, but if you could just recapitulate in short.
In walking epidural, it is either an epidural or a combined spinal epidural. The doses that are used are same as that is used in a conventional epidural infusion. So the bolus, if you're doing an epidural, the bolus would be 0.0625% bupivacaine or the bolus would be 0.125% bupivacaine or 0.2% ropivacaine with 2 mics per ml fentanyl. As an initial bolus, we give 10 ml as 5 ml aliquots, after which we reassess the sensory level. And if it is up to T10, that is sufficient. And after placing the patient with left uterine displacement, we start the continuous infusion after half an hour. This is more dilute solution. That is 0.0625 bupivacaine or 0.1% ropivacaine with 1 mic per ml fentanyl at 5 to 10 ml per hour. Now, if you're using a CSE technique, what you would do is you give the spinal component either with fentanyl alone or fentanyl with probably 0.5 ml of hyperbaric bupivacaine. And when the spinal component wears off, you can top up the epidural.
Okay. Thank you, ma'am. There is one question on the use of epidural ketamine. What is your experience here about that?
Epidural ketamine. We haven't used epidural ketamine as such, only in cases where we get desperate. In the second stage, we have used subanesthetic doses of ketamine by sublingual route. That is the only time we have used ketamine. not epidurally.
I mean, as far as I know, drugs like clonidine, dexmedetomidine, ketamine, neostigmine are all maybe tried in other epidurals, but is not licensed to be used in labor epidural because there is dearth of studies. Also, sufentanil is something that is said to be used, I think, in America, but mostly most centers use only fentanyl.
Right, ma'am. Can you just tell us your institutional practice about how do you monitor these patients? What are your protocols after placement of the epidural up to the delivery?
Postgraduates.
In our institution, we have trained personnel available for the monitoring. Along the nurses in the labor room and also anesthesia technician will be available. And our labor room is so near to our operation theater. And it will all these monitoring and the bolus doses are monitored and supervised by a trained anesthesiologist.
So what points do
Before
you actually
institution of
monitor?
epidural, as she said, standard monitors are kept, and after giving the initial bolus, every 5 minutes for 15 minutes, we do check the heart rate and blood pressure. With CSC, there is this risk of fetal bradycardia after giving the spinal component, which is very high in the first 15 minutes. The fetal bradycardia is said to be caused because of sudden cessation of pain. This decreases the amount of maternal epinephrine. So what happens is because there is decreased maternal epinephrine, there is loss of tocolytic effect, which results in hypotonicity of the uterus, transient. So in that time, patient can have fetal bradycardia. Sorry, not the patient, the baby can have fetal bradycardia. This can easily be remedied by maintaining left uterine displacement, giving oxygen, and if there is oxytocin on flow, make sure that you stop it. After that, every 5 minutes, there is standard monitoring. Patient is in left uterine displacement. They do take clear fluids, and our labor room is just adjacent to our operation theater.
Ma'am, there's a question on till what stage of labor can the epidural catheter be placed?
Epidural catheter is only taken out after the delivery of the baby, and the episiotomy is sutured. After delivery of the placenta, an epidural is sutured.
When do you institute? Up till what stage of labor can you institute the epidural?
We get a lot of labor epidural requests, and we do get them. This is like ACOG recommendation. Whenever it is that the mother says she wants the epidural, we are entitled to give it because we are a 24-hour labor analgesia service department. So we do give it very late in labor. And if the patient is very uncooperative, what we do is we give a single shot spinal and reassess. And if the patient is delivering within 1.5 hours, it is sufficient. But otherwise, we place an epidural catheter as well in a very calm patient after the spinal. We give put the epidural and top it up as and when necessary.
Yeah, I think, ma'am, all our questions have been
Now
answered.
I request Madhuri ma'am to kindly say a few words. Ma'am is also a pioneer in obstetric anesthesia.
No, Riddhima, I'm not a pioneer.
Actually, ma'am,
Okay.
teachers cannot escape without
Okay,
giving you
okay, but thank you very much, Shalu ma'am and Shalini ma'am, for that excellent presentation. Actually, I was very happy to know that you're the pioneers in labor analgesia, and this was an excellent presentation from God's own country, isn't it, Riddhima? And the questions that you asked, especially the question answer session, was really practical, and that really shows your exposure to the cases. How many cases of labor analgesia you must have given? So very practical questions, and they're very useful even for the practitioners, I'm very, very sure. So here I have one question.
Yes.
This can be to anybody, like, what about the Remifentanil? You know, Remifentanil is being launched on 1st of November in India. So this Remifentanil is said to be useful in labor analgesia. So can you enlighten us on the, how remifentanil would be useful in labor analgesia and how we could use it for labor analgesia? I think Shalini ma'am can tell us.
We
Yeah.
also have very little exposure. We are also waiting for the launch of Remi. I was just talking to a colleague in UK. So it is not licensed to be used in epidural, but they do use PCA pumps. I'm not
Yes,
very sure about the dosage.
exactly. See, remifentanil, it contains glycine, and it is not at all to be given by central neuraxial route. So you cannot give it intrathecally and you cannot give it epidurally. But IV, yes. So it is very useful for patient-controlled analgesia. That's what they have told. I read a lot of literature, and it is not a new drug. It may be a new drug for us, but it is already there since 1990s, 1996, marketed as Altiva, and it is being used in the USA and the UK. And there are so many studies and there are clinical experiences which say that it is good in labor analgesia, but somewhere in the pyramid of, if you see the pyramid of modalities being used for labor analgesia, you have the non-pharmacological modalities at the bottom, at the base. You know, all those immersion technique and all those. Then next is the pharmacological methods. Okay, opioids and non-opioids. And then you have these opioids. And next comes remifentanil. And then, of course, at the top is our epidural. So you have already explained epidural in details. So I think remifentanil, as you said, we will have to get exposed to its use, and only with experience we will be able to, enlighten.
The advantage is it's very short, context sensitive, half time.
Yes, it's only 3.2 minutes, the context sensitive half
They
time.
say in UK the
And
only I was talking to a colleague and he was telling me the only real need for epidural now there is labor analgesia, because for everything else they have started using blocks and block catheters because
okay,
of the complications related to CNVs.
exactly. But still, it is a promising agent. So let's see how it goes in our country. And
Can I add, Madhuri?
Sure, ma'am. Sure. I think Indrani ma'am is online. Ma'am, welcome to the PG online class. So please give your
Yeah,
valuable inputs.
yeah, thank you so much. See, remifentanil is not the gold standard for labor analgesia. We all know that. So it is going to be epidural or combined spinal epidural, which will be gold standard. Only if there is failure or if there are, other reasons wherein you can't use the neuraxial route, only then remifentanil can be used. However, in India, remifentanil is not going to be licensed for labor analgesia. I mean, of course, there are a lot of people who use it even if there is not licensed. I'm sure people are going to start using, but officially, there is no license for labor analgesia. That is number two. And number three, what I want to say about remifentanil is, see, usually, and as you rightly said, we have to give it by the intravenous route, and a neuraxial route is a big no-no. And because of the larger volume of distribution in pregnant patients, the dosage which is to be used is literally half the dosage of a non-pregnant woman. So that has to be kept in mind. Even if you're using it for labor analgesia, you have to give it at half the dose. So it will be something like 0.3 or 0.5, milligram per kilogram. So it's going to be like that. So that's another thing which I wanted to tell. And another thing about remifentanil is it is going to cause some amount of bradycardia. You have to have some patience. Bradycardia in the mother, not the fetus. You have to have some patience, but it will pick up. There will be no fall in blood pressure.
Yes, ma'am. And one more thing we can just caution everybody is that it can cause severe respiratory depression and episodes of apnea. So they say that you have to really monitor the patient very, very well. In fact, a
Yes,
1:1 ratio of patient doctor, patient midwife, that is what
that's
is advocated. And
very
you will
true,
have to
very
give
true.
supplemental oxygen. So it
Yes,
cannot be that we just put a remifentanil pump and go away from there. That's not
that's
possible.
true, very true, very true.
Exactly.
The standard, you have to keep monitoring the patient, very true.
Yes, yes, yes. And that's
And
what.
it
So,
and it doesn't have any, most 80 to 90% of the time there is no effect of respiratory depression in the fetus, because the half life is only like 6 minutes. So it's not going to affect the fetus. However, fetal resuscitation have to be kept ready. You have to keep your bag mask ready for the fetus also.
yes, madam. It crosses
Yeah.
this is for the benefit of the postgraduates here. Remifentanil crosses the placenta very, very easily, but it also undergoes fetal elimination very fast. That is it. Okay. Okay. And coming to that's what madam was talking about, respiratory depression in the mother and the fetus. So, what is the role of keeping opioid antagonists in the labor room? When you give labor analgesia, which opioid antagonist do you use in the mother and which opioid antagonist do you use in the fetus? Can you just elaborate on that, Dr. Princey, or your colleague?
Alvin.
Yes, Albin. Albin. Yes. Can you just tell us?
Naloxone is what
Can
is
be
used.
used.
Okay,
So in our
ma'am.
with our neonatologists,
What is your experience like? With different kinds of opioids for epidural, or what is your experience with
epidural,
the respiratory
we
depression?
we have actually never had any problems, hypotension or respiratory depression. The only time we have had an episode like that was when we used to initially give conventional epidural test dose, which was 3 ml of 1.5% silicane with adrenaline. So once what happened was one of the consultants had given it, and after that, when the patient was made supine, she became unresponsive. She did have a pulse, and the consultant could bag mask ventilate and maintain the oxygenation, but she was not able to intubate. And because the labor room and our OT is so close by, patient was brought in for cesarean section, and we did not try to intubate the patient, but cesarean was done under LMA because the intubation seemed so difficult, and it was uneventful post surgery. The mother and the baby were fine. Other than that, all our patients are closely monitored. We have trained staff and then our postgraduates as well as us. So what the neonatologists do with the baby is, if they see there is depression and we have given a spinal with fentanyl or with our epidurals, they do give naloxone to the baby. We have never had an episode where we had to give it to the mother.
Okay, so if you give naloxone to the baby, can there be any problems in the baby?
Naloxone we have not given, neonatologists have given. And the thing is
Okay.
actually naloxone is very short acting.
Yes.
But they will give it,
Yes.
and it needs to be repeated or given as infusion is what the theory says.
Exactly. Exactly. And what are the other routes of administration of naloxone? This is for the postgraduates. Intravenous, muscular, any other route? Can you give it endotracheally? Through the
nasal
endotracheal
sprays or
route?
intramuscular or nasal sprays.
Uh-huh.
Through intramuscular or nasal spray.
Okay. Okay. And the new modality has, I don't know whether it is, we would call it as new or what, but we have these immersive virtual reality which is coming up. So can you just tell us something about immersive virtual reality? Of course, it has nothing to do with neuraxial blockade. With the era of artificial intelligence coming up, so we have this immersive virtual reality where you create an artificial situation for the mother and try to distract her from the pain of labor. And this is most often used in the first stage of labor when the when the pain scores are less. It should be about visual analog score less than 8 or so. Okay. Yeah. So, any other any other questions from the audience, Ridhima? Just check.
Yes, ma'am. Dr. Niani is
Hello,
there
ma'am.
in
Hello.
I think
Yes, please.
Hello, ma'am.
Please. Yes, please.
My question incidentally was not taken up. I'm a freelancer, and my
Please,
question
please,
was
please ask.
my question was when we convert a labor analgesia into a cesarean section, the surgical anesthesia,
Hmm.
they said either you use 0.75 ropivacaine or 1.5% xylocaine or 0.5% bupivacaine. I think, am I right?
Yes.
I have heard
2%,
it correctly. Have I
2%
heard it correctly?
2% xylocaine with adrenaline.
2% or 1.5%? Hello.
You can use 2% xylocaine with adrenaline, 0.5% bupivacaine, or 0.75% ropivacaine. You can use it as a single drug, or you can use a mixture of them in
And
combination.
yes, I understood. Thank you, ma'am. What is the quantity like? 10 to 12 ml or more?
We usually need to give up to 15 ml. That's what we have seen.
15 ml, 1.5.
1.5. So we
Okay,
make
thank you,
it
ma'am.
as 12 to 15, depending on how short or tall the patient is.
Yes, the height of the patient and all. Thank you, ma'am. Thank you very much.
Any other questions, Ridhima, in the
so,
chat
ma'am,
box?
I think all are given answers. There is no questions. Only appreciation for the madam and the class.
And then I think we also have a role of ultrasound guided epidurals, right, for labor analgesia. Ma'am, you want to say
Yes,
something on that?
for obese patients, it's difficult to identify the space. For
Yes.
example, the other day we had a 132-kilogram patient for labor analgesia. We do not have long epidural needles, but we could manage with the one we have. And the space was difficult because there was uh, a ball of fat in the middle. So we had to use an ultrasound to help us identify the space.
Exactly. And I think it's very useful even in patients with preeclampsia, right, where the back is edematus and it is really difficult to get in an epidural in those cases.
Ma'am, one last thing I wanted to ask.
Yes, sir. Please tell.
When many times it has been said the single shot analgesia, you give half cc or 2.5% of bupivacaine heavy with fentanyl about 20 to 25 microgram. So can that 2.5 mg of heavy bupivacaine lead to fetal bradycardia? Because that is the concern of the obstetricians always. While giving a single shot spinal for labor analgesia, 2.5 mg or half ml of 0.5% bupivacaine, can that lead to fetal bradycardia?
The spinal component in a single shot spinal or with CSE, there is usually high incidence of fetal bradycardia. Why this happens is because of sudden cessation of pain. Like I explained before, the maternal epinephrine levels will fall suddenly, and epinephrine has a tocolytic action on the uterus. So when this epinephrine falls suddenly, this tocolytic effect is lost. So there will be transient hypertonicity of the uterus, which leads to fetal bradycardia. This usually occurs after or within 15 minutes of you having given either the spinal component in a CSE or a single shot spinal. So we should be watchful. It is usually correctable. What you have to do is make sure you maintain left uterine displacement, give oxygen to the mother, and if there is some oxytocin on flow, you have to make sure that that is stopped, and usually it recovers.
So it is the hypertonicity of the uterine muscle that causes this.
Yeah, hypertonicity will decrease the uteroplacental circulation, thereby causing fetal bradycardia.
One more thing the obstetricians do is in such cases they start ringer, if at all. It's always almost running, but if not, they'll start ringer because that is to prevent acidosis in our setup at least. Thank you, ma'am.
I think generally you just observe, have little more patience. I know it's difficult, but with little patience, I think the heart rate recovers.
Yes, yes.
generally.
Ma'am, but here the situation is altogether different in an institute and a freelancer practice. That is the thing. They are all worried about fetal bradycardia. Thank you in any case for extensive explanation about this.
Yes, and whether this fetal bradycardia, the incidence differs between the use of if you're using bupivacaine, levobupivacaine, and ropivacaine, like
not
the safety in the mother and safety in the fetus. How is it variable between the three,
Yes, yes. Thank you. Good question, ma'am.
the three
Thank you.
local anesthetics?
Can
We
the
have
expert answer?
we
Yes.
have
Yes,
used
ma'am.
we have used levobupivacaine in the same way as we use bupivacaine and hyperbaric bupivacaine, and haven't found any difference. The heavy ropivacaine I haven't used for spinal. Levobupivacaine has the same effect as bupivacaine.
Riddhima, I think Dr. Raghunandan has got some questions. Please ask those questions from the chat box.
Okay, let me see. Ma'am, is it visible to you? I can only see Naomi's Dr. Raghunandan question.
Questions, Riddhima, ask those questions. Please ask those.
I'm not able to see, ma'am. Is it the Raghunandan sir's question somewhere
Yes,
down?
yes, they are. Please ask those questions.
Achita, can you see that questions?
Yeah, monitoring during labor analgesia is the most important part of the whole procedure. So sir actually wanted to get a protocol monitoring chart for labor analgesia. So if it is possible for our experts to provide us with a monitoring chart is what sir is asking.
What we have is a initial anesthetic docket, which like a patient is seen for anesthesia, there is a pre-anesthetic docket with all the information. And then after giving epidural, all the parameters are documented as we would document in a patient for anesthesia. That is the monitoring chart we have. Pre-anesthetic document of docket and also a monitoring chart, like what we do for anesthesia.
Okay. Thank you, ma'am.
I think somebody wanted this, Dr. Mohan Pathak. Is this done? Please repeat dural puncture epidural technique. Are you done with this question?
We are done with, ma'am. I think we should tell everyone that all this recording will be available in ISC NHQ. So all these questions are already discussed. You can just log in the YouTube and see that.
Okay. Okay. And there's another thing on monitoring during labor analgesia. Have you covered that?
Yes, ma'am. It's already being answered by Dr. Shalu, ma'am.
Okay. So anybody in the audience who would like to add something to this very good discussion?
Hello.
Yes, Dr. Mohan Pathak. Sir, please ask, sir.
Madam, I think you have told that in case of inadvertent epidural puncture by 2E needle, if you puncture the dura, the dose of saline they said I think 1.1 liter or 1.5 liters. Is it okay?
I think
Installation of the normal
that
saline
is
in
a
the
very
epidural
high dose.
space.
Yes.
So you can put the saline in the epidural space.
Yes,
I have had 2 cases of dural puncture during epidural, and unfortunately it happened to be one of the VIPs, one of our own colleagues' niece. And the 2 problems which I came across was one, I couldn't, I took out the epidural catheter and epidural needle and placed epidural in another space. And
Yes.
the problem was I couldn't sit the patient up. Unfortunately, the she couldn't be sat up because she had severe headache immediately post this thing. But somehow propped up and gave epidural and delivery was over. And this patient, I had given 100 ml saline through the epidural space before taking out the catheter. But this patient had post-dural puncture headache, which lasted for intense headache, which lasted for 5 days. And till she was discharged on 7th, she was okay. While two other patients, they had the same experience. Those patients are given 100 ml saline at the end, and fortunately, they did not have any post-dural puncture headache.
Ma'am,
Of course,
can I add something to this?
yes.
Yes, please, sir.
So, madam, I also thought this dose of normal saline to be too high somehow, because I was studying way back in 40 years before. I read somewhere in our textbook Wiley that you can give 20 ml of saline, and that goes a long way in preventing post this thing dural puncture headache. And this exactly I have tried in 2 patients so far, because see, every week I get, not for labor analgesia, but I get about 2 to 3 patients for epidural steroids referred to me by my orthopedic surgeon. And what happens is these patients are on OPD basis. You cannot admit them. So what I did was, twice I injected, after giving the epidural steroid, in another space I injected about 20 ml of saline, and fortunately for me, I don't know how did it work, but none of them, both of them, had no headache. So I think, if I'm not mistaken, of course, this was 40 years back when I studied, but I think it is 20 ml of saline written in our textbook of Wiley and Churchill Davidson. I don't know how to go back to it, because then in private freelancing practice, we hardly refer textbooks. But this is what I have to say on this about
The
epidural saline.
the references are different. There is reference for 500 ml, 1000 ml, and 1.5 liters. I think that 1.5 liter is spaced out in 1 to 2 days post this thing, post dural puncture, while the one which I followed was about 100 ml saline just before taking out the catheter immediately after the labor, after the delivery was over. So there different books give different references.
Exactly. Yeah, this is a good learning for me. Yes.
Yes.
There are
And
references for half a liter,
Anybody
1.5
have
liter, and that may be spaced out in 1 to 2 days, while the 100 ml saline is to be given immediately after. And there are other references which say that is obsolete, but experience has shown that it does work. And the theory behind it is that I don't know how it works, but the theory behind it is that the epidural space is pressurized so that
Exactly.
leak
So it
does
prevents
not
leakage. Yes.
leak does not happen from the subarachnoid space.
have anybody got the experience of epidural blood patch?
Yes, not for
Epidural blood
post-dural puncture headache after anesthesia, but I have myself given 5 epidural blood patches. That was for neuro patients who had
benign intracranial hypertension.
no, this is a rend in the one was a patient with a rend in the dura due to head load worker who had slipped, and there was a rend in the thing, and 2 other cases were accidents. Then there are 3 other cases which had spontaneous. In all these things, all these patients, it did work.
Ma'am, you give 15 ml blood?
20
ml
ml.
of the autologous blood.
Autologous
Twen-
blood.
20
And
ml is what?
in the same space?
Epidural space.
And this
In the
was a
same intravertebral place where you have given epidural?
This is not for epidural. This is for neuro patients who had
Neurological
come with a
cases.
spontaneous this thing. and the MRI had shown the area of rent, so we placed it in the middle.
Okay, okay.
And
That was a therapeutic for that. Okay. But this
For benign intracranial hypertension, we have given once only.
So please tell your experience. Dr. Mohan Pathak?
Yes, for benign intracranial hypertension, once only we have given epidural blood patch, not for
Okay, sir.
PDPH.
Okay, sir. I think
That's it.
Dr. Srilata ma'am is here. She has also got very good experience with these labor analgesia. Ma'am, you want to add something?
Madam,
Yes.
for comparative study, we have done with levopropaquine and ropivacaine.
Okay.
With ropivacaine, incidental deliveries some are minimal, madam, when compared to levopropaquine.
Okay.
So that is, we have done a thesis for our students.
Okay.
So outlet forceps are, chances of outlet forceps are very low with 0.25% ropivacaine, madam. And also regarding the blood patch, we have given autologous for PDPH successful.
Okay.
20 ml we have given autologous blood transfusion.
In the
Blood
same
bank.
space you gave? In the same space?
Yes, madam. Yes, madam.
Okay. Thank you so much, ma'am. Thank you, Srilata ma'am.
Thank you, madam. Thank you, ma'am.
Anybody else wants to add, Ridhima? Any other questions in the
Yes,
chat
ma'am.
box, or we shall wind up then?
ma'am,
Ma'am.
Yeah. Yes, sir. Please.
last
Yes,
one,
please.
if I
Yes,
want
please.
to, if you want to, because see, couple of times I've been trying to practice analgesia for labor analgesia for long now. But the problem is my obstetrician say that you yourself come and top up the dose, which is not possible for me. So what I did couple of times was when the patient was in advanced stage of labor and this single shot spinal technique was not known to me, couple of times I have done so that ropivacaine 0.25%, 0.2% with 2 mg, 2 microgram per ml fentanyl, I have injected as a single shot epidural when the patient is roughly in the last stage, phase of first stage, that is about 9 centimeter or 8 to 9 centimeter. So I did that. Patient had quietened down, and by the time they finished the first stage, and in second stage the patient had little pain, but then they delivered. I mean, a couple of times I did that as a single shot epidural, not a single shot spinal, which now I have learned today.
Thank you, sir. Thank you so much for your inputs. That was really very, very useful to us. Ridhima,
Yes,
we have,
ma'am.
I think we have covered most of the things.
Yes,
So we will be concluding the session. So we will now award the certificates to the faculty and the postgraduate students and the coordinators from the ISA National as a gratitude for their participation in this class. And before that, I would like to thank, on behalf of Dr. Bajwa sir, Honorary Secretary ISA National, I would like to thank the faculty, Dr. Shalu Ipe ma'am and Dr. Shalini Miriam Ipe ma'am, for this very excellent presentation. They accepted the invite and they have really done very good justice to the topic. And we also thank the postgraduate students, Princey Thomas and Albin Joseph. I think they answered beautifully and very confidently. And I'm sure that with their teachers, they must be having first-hand experience in giving labor analgesia. So not many postgraduates in the country are really good in giving labor analgesia, and I think you boys and girls are really very lucky. Okay, and with that, we will now share the we will award the certificates to the presenters. Just bear with me till I share the screen for the certificates.
I think Princey and Alvin, you can relax now. It's a wonderful class.
Can you see the
Yes,
certificate?
ma'am. Yes,
Ridhima?
ma'am. Yes,
Okay,
ma'am.
so the first certificate is awarded on behalf by the ISA National to Dr. Shalu Ipe ma'am from MOSC Medical College, Kolincherry, Kochi, Kerala. Ma'am, thank you very much. We're very grateful to you for participating in the class as faculty. Next.
Thank you.
Next, Dr. Shalini Miriam Ipe ma'am from the same department for participating as faculty in the ISA online PG class. Thank you, ma'am.
You're always welcome. Thank you.
The postgraduate students, Dr. Princey Sarah Thomas from the department MOSC Medical College, Kolincherry, Kerala for participating as a postgraduate resident in the class. Congratulations.
Thank you, ma'am.
Next is Dr. Albin Joseph, postgraduate resident. Thank you.
Thank you, ma'am.
Then we have our own coordinator, Dr. Archita Patil, Associate Professor, Department of Anesthesia, D.Y. Patil Medical College, Kolhapur. Archita, you did very well. You did very well. And I'm sure we look forward to your contribution in the future for the ISA National PG online class. Congratulations.
It's my honor. Thank you, ma'am. It's my honor.
And then we have our own senior coordinator, Dr. Ridhima Sharma. Very sweetly, she presented and coordinated the session. And we are very grateful to her. Thank you very much, Ridhima.
Thank you, ma'am. It's always a learning with you.
Yes. And these certificates will be emailed to you shortly.
No certificate for you, ma'am. You summarize it so well every time. Every time you summarize it so well, Dr. Madhuri Kurdi, ma'am.
Thank you so much. Thank you so much for that.
Okay.
Yes. So with that, I think we will end this session. And no session is complete without saying, long live ISA. So let's all say together, long live ISA.
Long live ISA.
Long live
Long
ISA.
live ISA.
Long live ISA.
Thank
Good night,
you.
ma'am. Good night, everybody.
Good night. Good night, sir. Thank you. So we end the session.